A very warm welcome to everyone here. A good afternoon to you. And we welcome you to this webinar, which is organized by Supra Software Solutions. This is on the artificial intelligence and HbA1c, the impact of it on smart reports and for better outcomes. A general housekeeping rules. Please keep your microphones on mute. And if you have any questions, please put it on the chat box. All questions, we will take it up once all the speakers finish their sessions. And if you have, the session is being recorded. The recording will be shared once the sessions are over. Before we begin, I would like to introduce the speakers. We have today with us a very esteemed panel of speakers who are experts in this domain. We first have Dr. Deepa Anantalakshmi, our first speaker. She's a consultant pathologist and founder of Dr. Deepa's Learning Launch, an award-winning author. She was recognized as one of India's top 24 most inspiring women in healthcare 2024. Her topic today is on peaks and valleys and HPLC-A1c Insight. Then we have, followed by Dr. Deepa, we have Dr. Satish Ramanathan. He's an experienced NABL and QAI assessor who served as a CAP team leader from 2017 to 2020. In his current position at Sukra, he's the implementation head for the AI division. In today's webinar, he will be deliberating on gap to leap challenges in reporting A1c in HPLC. Followed by him, we have Mr. Sridhar Paripurnam. He's the founder and director of Sukra Software Solutions. Mr. Sridhar brings a wealth of leadership to this field. He will be leading our exciting product launch for AI in A1c. The session is being moderated by our only most knowledgeable Professor Dr. C.N. Srinivas. He'll be moderating it for today. And he will also lead us in our final session, the Quizzards of Oz Mega Quiz. Thank you all for being part of this wonderful webinar. I hope you have a lot of takeaways from this. Over to you, sir. Dr. CNS, sir, will take it forward from here. Bye-bye. Thank you.
Thank you for the introduction.
Good evening, everyone. Are you able to hear me?
Yes, sir. Good evening.
Yeah. So we have today the first presentation by Dr. Deepa Anantalakshmi. May I invite upon Dr. Deepa Anantalakshmi to take on the stage to deliver the address on HbA1c. Dr. Deepa, please go ahead.
Sure, sir. Thank you. Good afternoon, all. A hearty welcome to this, and thanks first to Professor Srinivas, sir, who gave me this opportunity to speak about my favorite topic in hematology, which includes working on the D10 system, which I have been doing for a long time. So I wanted to explain how HPLC is looked at, because that's a very important topic. Diabetes is very rampant now. It is not what it used to be. As you know, our lifestyle is changing, our stress levels are changing. So now also that we are looking at a holistic healthcare approach. So there are clinicians who want to check on diabetes before it happens. And you have the increased number of diabetics in India, which has gone up a lot more than it used to be. When we never heard of our grandparents suffer with diabetes as much as our community is suffering right now. So the first topic, I will be explaining in detail the basics of what the peaks and the valleys look like. So the topic that was given to me was peaks and valleys. So I will run you through the basics of what HPLC system is, and I will go into much of the details. So I am Dr. Deepa. I have already been introduced. So this will be the learning objectives today. So the learning objective will be understanding the biochemical basis of HbA1c, the methods that are available for HbA1c. Then you will also look at the principles of the HPLC separation, understand the stepwise methodology for the same, interpret the chromatographic peaks, recognize the common analytical interferences. This will be taken much more in detail by my successive speaker. And we will go in touch base on the clinical correlation also. Where do you have to pick up your call and talk to your clinician? So that is where I will be running you through. So if we let's look into the biochemical basis of HbA1c. Before that, I wanted you to know how this gets divided in our HPLC report. So this diagram basically illustrates what exactly are you able to see. So this diagram basically illustrates the proportions and the clinical significance of various hemoglobin fractions. So if you look at the hemoglobin fraction, then if you look at the adult hemoglobin, that occupies 97% of the hemoglobin fraction when you look at the HbA1c plot, which is 2 alpha and 2 beta. 2.5% is a HbA2. HbF, which is 2 alpha, 2 gamma, occupies about 0.5%, which is the fetal hemoglobin. So basically, the hemoglobin is the oxygen carrying capacity of the red blood cells, which is composed of 4 globin chains, which is surrounding a central heme moiety. So based on the subtype of the globin chains, it is classified into 3 major physiological forms. First is the HbA, which is the adult hemoglobin, which has 2 alpha, 2 beta chains, comprising about 97% of the total hemoglobin in normal states. With HbA2 is the next commonest one, which is 2 alpha 2 delta chains, forming approximately 2.5% of the total hemoglobin content. And the third is HbF, which is 2 alpha 2 gamma chains, accounting for about 0.5% of the total in a normal adult. That is in a child, HbF obviously is high, so that normalizes at about 18 months of age. That normalizes to form the adult hemoglobin. The HbA, which is the predominant and the most important fraction, is further divided into the non-glycated hemoglobin, which is HbAO, which accounts for 94%, and the glycated form, which is the HbA1, forming about 5% of the entire adult hemoglobin. This is produced slowly by and this HbA1 production, the glycated fraction happens by a non-enzymatic irreversible binding of the circulating glucose to the hemoglobin in proportion to the blood glucose level of an individual. The HbA1 is further divided into HbA1a, A1b, and A1c. The A1c, of which HbA1a, A1b are present in low concentration and are not very measurable in the usual scenarios. Very small quantity which appears as the preliminary peaks in our HPLC. The A1c, which is the major part, is clinically most significant component. So this component is what we are looking at. This is the clinically most significant component of for a diabetic individual. So the HbA1c is formed by an irreversible attachment of glucose to the N-terminal valine of a beta-globin chain, which reflects the average plasma glucose concentration over the preceding 8 to 12 weeks time. So they say it's 120 days, but like I said, the lifetime of an RBC changes from individual to individual. So on an average, it's 120 days on the basis of presence or absence of an abnormal hemoglobin in your bloodstream or the clinical conditions. Where the productivity can get impaired in case of iron deficiencies or in any other protein deficiencies, there is a slight variation. So on an average, they say it gives you a scenario between 8 to 12 weeks. This is corresponding to the RBC life of 120 days, making it the gold standard marker for diagnosing any diabetes mellitus, monitoring diabetes, and long-term glycemic control index. This is very, very useful in case of chronic diabetes. So like I said, the key biological event that occurs is when glucose binds specifically to the N-terminal valine of the beta-globin chain of a hemoglobin A. I told you there are 4 globin chains with a central heme moiety, so central ion. So that is what is the structure of the hemoglobin. I just wanted to show you this. And what happens is that when the N-terminal valine residue of the beta chain of the hemoglobin A forms a stable covalent bond through a series of chemical rearrangements, initially it forms a Schiff space. Then there is an amidori rearrangement that takes place to stabilize it further into a ketoamine structure. So this irreversible modification results in a glycated hemoglobin, which is called HbA1c, which you are measuring. Since the RBCs have 120 days of lifespan, that is why it is a biochemical memory of your glycemic index for about 120 days. Then how is it actually calculated in your machine? The HbA1c is the glycated hemoglobin divided by the total hemoglobin A represented in a percentage. So in other words, it is the proportion of the glycated hemoglobin relative to the total hemoglobin that you're measuring. So once I'm done with this basics, I will move on to the methods available for HbA1c. So what are the methods that are available for HbA1c estimation? So for HbA1c estimation, what we are doing, and mind you, we are not talking about fructosamine test, which has nothing to do with RBC. We are dealing with only the ones which has everything to do with RBC. So these are the methods available for HbA1c estimation currently. So these include ion exchange HPLC, affinity chromatography, immunoassays, enzymatic assays, and capillary electrophoresis. Of these listed, the affinity chromatography, immunoassays, and enzymatic assays do not detect variants. So that is a negative point here, which I wanted to tell you. So by far, the HPLC technique that we are using commonly in the laboratories remains to be the gold standard. One, because of its availability, the trust that people have on this, because the interference with the variants can be picked up very well. And it offers analytical accuracy, which is very much traceable. So the accuracy and precision is traceable. And the visualization of the chromatograms is what makes it superior over other methods in which there are no variability and variant detection. And it also has an NGSP IFCC traceability. So these are the reasons why HPLC remains to be the gold standard methodology. So to understand the principle of HPLC separation, I just wanted to go back a bit in history. So the word chromatography, basically chromatography was described and discovered by Michael Sweat. So he had done a research on plants, basically, where he realized that compounds can be separated on the basis of their color. So this has been adapted in the high performance liquid chromatography also, where you have an injector system, a pump system, analytical column, mobile phase of buffers, a detector which is photometric detector, and you have finally the data acquisition, which is done by a data processor and software. So this is a default that is there in all the types of HbA1c instruments that we have, whether it is D10 or it's Tosho or any of the ones that are using HPLC. This is the basic. The HPLC column that you keep changing according to the manufacturer's time limit of usage. So the HPLC column is packed by a cation exchange resin, which is negatively charged at the bottom. So the hemoglobin molecules are slightly positively charged to more positively charged based on which type of variant is there in it. So on the basis of the charge, the one that is very loosely attached or low positive hemoglobin is held very short while the ones which are more positive hemoglobin are held for a longer while. So on the basis of this charge, when the hemoglobin is moving from one end to the other end on this cation, on this column, the ones which are loosely attached are eluted first, and the one which is tightly adherent to the negatively charged base is given out later. So that is the basic mechanism in which hemoglobin is eluted. So any of these systems have two ways in which the system works. One is the 3-minute in which your A1C is calculated. So this is what I was talking about. The analytical cartridge is negatively charged and you have different charges of hemoglobin. Finally, it elutes out and the detector picks it up based on the charge. So no matter what type of instrument you have, there is a A1C mode and A2 mode in most of them. So the A1C mode basically is a short assay in which the variants are not picked up. You need to do a 6-minute long assay for the variants to be picked up. Today, we will be restricting ourselves to only the A1C mode. So my talk today will be on the basis of D10 Biorad instrument because I will be putting out those charts for understanding. It's a very commonly used instrument here. So it's a fully automated high throughput hemoglobin analyzer which provides integrated approach for sample preparation and determination and percentage relative to the value. So in D10, the samples are just injected automatically and then the D10 delivers a program buffered gradient on the basis of ionic strength. They are eluted and the hemoglobins are separated and then passed through the flow cell to the filter photometer. The photometer where there is an absorbance at 415 nanometer, it is measured. So the HbA1c measurement takes roughly 3 minutes, while the A2 in this instrument takes 6 minutes. And the detector absorbs at 415 nanometers. The 415 is basically the Soret peak of the hemoglobin. So that is how it is measured. So next we will look at the stepwise methodology. So usually for any of the HPLC measurement, the sample that is utilized is an EDTA whole blood. And of my experience, I'm telling you the best is to get the fresh sample out of a patient. It is very relevant in case the patient is having any of the variants, like suppose you have a hemoglobin BARTs or any of the HPH variants that you're detecting where you still have to do a supravital stain. to find out the variant later on, it will be a good idea if you have a fresh sample. And fresh sample also has less interferences. Once we show you the peaks, I will show you what happens if you have a degenerated sample as well. So ideally, and for any of the laboratory tests, carpet rule is it is better to have a fresh sample. But in cases where you do not have a fresh sample, you can keep the EDTA blood stable at 2 to 8 degrees for as far as 7 days. That is the maximum that you can test it. And some of the instruments require you to produce a hemolysis preparation in which you will mix, they will give you a chart in which you have to dilute your EDTA sample with the buffer or with the reagent that they are giving you before you put it in the instrument. Some of them have automatic dilutions also, where you do not have to do that one step of hemolysis preparation. So the hemolysis happens inside the analyzer. So you have to look at your whichever instrument you have. You have to find out whether you need to prepare the hemolysis before or after, and according to that, you will be loading the samples. Then when you switch on and start the instrument, first carpet rule for all the instruments that works in hematology or any instrument for that matter, check the QC and the baseline pattern for sure. Identify if the baseline peaks and everything are in, every peak touches the baseline and the retention time are accurate. If it is identifying each of these peaks, look at the QCs first. Quantify or quantity of the peaks are next looked at. The quantity of the peaks have to be in line with what the manufacturer tells you for those QCs. That also has to be checked. Then look if there are any variant windows. And if any of these, if you're finding any abnormality, you need to correlate that with the family history, lab values. For example, if there is a high HbA1c, you would want to look at his plasma glucose if it is available in your lab and check. And if there is a variant, you would want to go ahead and advise for an A2. Look at the name, the ethnicity, advise accordingly to pick up your call the clinician, and that's how you go about the analysis of A1C plot also. So let's then move on to the most interesting topic today, which is interpretation of the peaks. So this is a very normal looking A1C graph. So A1C graph, just like I told you, what are the peaks? The peaks are the A1A, the A1B, the F, the fetal. These are before A1C. And then you have the A1C plot here, and you have the P3. This is the AO, and this is what it looks like. So when I'm looking at this plot, what do I first see? I first see the most important thing is if the total area is accurate. The total area is 1 to 5 million for a D10 instrument. Every manufacturer will give you a particular amount of total peak area, which is manufacturer and machine specific. You have to first look if the whole run itself is valid. So if there is a problem with that, you will have to dilute it. Suppose there's a patient with a very high hematocrit and the peaks are coming really, really high, then you will have to dilute it a bit. So like that, you will have to look and make sure that the manufacturer's range of total area is first satisfied. When you're looking at this first, if it is satisfied, then you move on to look at everything else. So then you look at whether all these peaks are touching the baseline here. So this is the baseline. It has to be straight. You have to look if all the peaks are touching the baseline. The next thing that you see is if the peak of interest for you is the HbA1c. So the HbA1c, look if the peak is shaped sharp and the tip is sharp. So the same way you have to look at P3 also, the tip has to be sharp. So any of these peaks should have a sharp tip, and all of them should be separated from each other, and they should look very uniform. So that is one thing that you have to look at in a normal peak. And in normal peak, as I said, this A1C value is 5.1, which is normal for according to the guidelines that we have with the American Diabetic Association or any of the standards that you're following. So this is a normal sample of a normal patient. So I just wanted to show you the peaks first. So when you're looking at this now, this is again a very normal peak. But here I wanted to tell you that one thing that you have to remember, a very easy method that I used to remember for D10 is the manufacturer tells you a particular range of hemoglobin F that is acceptable for reporting out an A1C, and a particular range of the variants that are acceptable for reporting an A1C without an interference. So that is something that will be available in your manufacturer's booklet, which you have to read before you interpret any of the peaks. Even though all the cutoffs that I just told you, your QC has passed, you're absolutely fine, the sample is okay, there is no hemolysis, there is nothing to reject the sample, you've run the sample in your instrument, you're able to look at the peaks are, total area is fine, the peaks are fine, the whole thing looks okay. But if there is a variant or if there is a fetal which is beyond the range of reportability for that particular instrument, you still cannot give out your A1C. So here, one thing to remember is the cutoff of F. The F is before the A1C on the left side. So these are the peaks. This is the area where you will be able to see the fetal hemoglobin here. So for the F, the cutoff for the D10 instrument is 10%. So if the fetal hemoglobin is beyond 10%, for that particular patient, the A1C is not reportable for D10 instrument. But if it is an instrument like D100 or variant turbo of Biorad, then that percentage goes up to almost 40%, 25% for the other two instruments available with Biorad. For any of the commercial instruments that is available, there will be a particular cutoff. You should remove your booklet and read that up and make sure you will report A1C only when the percentage is within that range. So like I said, you have to remember that the fetal hemoglobin for reportability of A1C by Biorad D10 is 10%. Below 10%, you can report the A1C, which means the fetal hasn't interfered. And if it is a variant, then it is 40%. If the variant is above 40%, you will not report the A1C. In the sense, if it is a homozygous or a double heterozygous variant that is there interfering, you will not report the A1C. Then what you see here, your total area is okay. Just look at the plot with me. This is how I report. So this is how you should report. So once you check the patient identifier, make sure it belongs to the same patient. The next in row is you look at the total area 1 to 5 million was what I spoke to you about. This is 2.5 million. So this is acceptable for me. And then what do I look at? I look at all the peaks here. All the peaks are touching the baseline. The A1C is shaded. And there are no abnormal peaks here. The fetal is within range. And then what do I see here? HbA1c is 9.2. So this is a genuine reportable plot. And the HbA1c is high. So this basically is a person who is having bad glycemic index, blood glycemic control. You would want to look at his previous value and probably pick up the phone and talk to the clinician with what value you have. So next we move on. Now that we looked at the normal, we looked at a normal plot. We looked at how much interferences are acceptable, 10% in case of the fetal, which is on the left side. And if it is a variant, 40% is your cutoff. So when you're looking at this in the plot, the next thing that we look at is abnormal interference. So all said and done, the main interferences will be taken care by my next speaker, but I still wanted to put a word. So the interferences of A1C estimation, like I told you, the hemoglobin variants, where you're taking 40% as a cutoff, the elevated fetal, 10% cutoff, the carbohydrate hemoglobin, which is commonly increased in cases of uremia, the labile A1C, which is the loosely attached glucose, the one step before the HbA1c. So that labile A1C. Hemolytic anemias or hemolysis of any kind can change the ratio and it will give you falsely low A1C results. Iron deficiency anemia, where you can have a little higher A1C also. Recent blood transfusion history is mandatory. If there is a patient who's having a recent blood transfusion history, absolutely you're running somebody else's blood in the individual. So A1C will go down. So A1C will not be correct or accurate. Even the variant fractions can change in case of a blood transfusion. So these are basic interferences that you have to keep in mind before reporting out an A1C. So let's look at this. Basically here, what you're able to see, the LA1C, the CHB1, CHB2, these are carbohydrate and labile hemoglobin ranges. I wanted to show you this plot. So why, when you're seeing the A1C is within this area, within these peaks, but it is shaded, it's being picked up. So how is your machine picking up this? That's a common doubt which I had, so which I wanted everyone else also to know. So the labile A1C and carbohydrate hemoglobin are the HbA1c of interest is the glycohemoglobin of interest, which is formed by two steps, like I told you, on enzymatic glycation of A. The first step is unstable aldemide, which is the labile A1C or pre-A1C. So that is what you're able to see here. So this is a reversible reaction between the carbonyl group of the glucose and the N-terminal valine of the hemoglobin chain. So the labile A1C formation is directly proportional to the blood glucose concentration immediately at that time. So during the RBC cell circulation, some of these labile ones are converted later by Ramadori effect into the HbA1c. So the D10 software, what it does is it performs a reduction of the raw data collected for each of these analysis. A two-level calibration is required for the same. And the chromatograph is generated in a way in which the A1C itself is shaded and it doesn't interfere with the LA1C. So this is calculated basically by the D10 instrument using an exponentially modified Gaussian algorithm. So what it does is that algorithm excludes the labile A1C from your entire plot, and it picks up only the A1C so that the carbohydrate sections are separated out from the A1C. So even if you see some amount of mix up here, The one that is shaded is definitely your second, after the second reaction, after the amidori reaction, whatever is remaining, the permanent A1C is what is there. So I used to have this doubt always. So I wanted to clarify for you guys also to know that A1C that you're getting in this D10 instrument is definitely not mixed with the carbamylated or the labile hemoglobin. So usually this interference with the carbamylated peaks where there's some amount of overlap like this, but still your instrument picks up the A1C properly. So this amount of mix-up is usually seen in cases of chronic renal failure. Some cases like urea-derived cyanate modifies the hemoglobin, those reactions, or when the labile fragment elutes very close to the A1C. Those are the places where you have a problem, which can falsely elevate your A1C. So you have to be careful if you're not using an instrument which is having this exponentially modified Gaussian algorithm. Suppose that EMG is not available in your instrument. So this labile also will get sometimes pushed and interfered with the A1C. So that is one thing you have to keep in mind. This separates it out. So it's not a problem. So this is again another peak I wanted to discuss. Total area is acceptable. 1 to 5 million was our cutoff. So you're seeing the A1C is a bit high, but you're also seeing some, if you look at all these peaks, you're seeing the P3 to be a bit blunted, isn't it? So this can happen sometimes. If I zoom out, you're seeing that the P3 is actually a bit blunted. There's a split. It normally should look sharp like this, but here there's a split. So this unknown split can happen sometimes in the instrument. So this has actually no effect on the HbA1c at all. But the P3 segment is very important because P3 also reflects the amount of degeneration of the sample. We sometimes work in a B2B sector where you have samples which come for both HbA1c and variant analysis, and then you have sample 3 days old, 2 days old, which they claim that they have sent in the right temperature, but you never know how it was sent, how it was picked up. So since most of our doctors do work in a B2B setup also, you never know whether the temperature chain has been kept, but there are certain quality checks that you do for it. In those cases, P3 segment will be elevated. So P3 segment elevation, there is a cutoff for any of this. If it's around less than 10%, then it is most likely to be degeneration. Suppose the P3 is to the level of, let's say, 14%, 15%, then it is more likely to be an alpha chain variant, which can be something like hemoglobin J murate, which is very common in our scenario. So when you're looking at P3, there are a few things that you have to look at. P3, you have to see if the peak is fine. This amount of small split that I showed you is okay, because sometimes when there is resolution that is very highly increased, you can see areas where you have these slight peak disturbance in P3, which is acceptable, does not change your HbA1c. But if there is excessive degeneration and P3 is, let's say, about 10%, 12%, don't report A1c on that. And if it is as high as, let's say, 15, 17, 20%, it's more likely to be an alpha variant. So in any of these, P3 segment is also important. One, to look at if it is degenerated. Second, to look at if there is a hemoglobin alpha variant which is interfering with your results. So any of these cases, do not report the A1c. Okay. So next we move on to these charts. So this is a chart in which you are able to see, this is let's say, look at this chart in which you are able to see the total area is fine. And there is some amount of fetal hemoglobin increase. It's 3.1, about 1% is what we expect in an adult. This is about 3%, but is 3% acceptable? I told you the cutoff is 10, so this is good to. So on your left, what you're seeing, it's good to go. You can report this HbA1c of 5.7. It's good to go. It's a normal value. Give it off. But on the right, if you see, you see LA1C compartment to be 25.4. So one very important thing to remember in D10 instrument is that whenever your fetal hemoglobin is about 16.5 is the cutoff that it gives properly into the F. But if it goes beyond 16.5, then it pushes it off into the LA1C. So what you're seeing here in the LA1C peak as 25.4 over here, this peak is actually fetal hemoglobin. And in thalassemia major, this can go up to like 90% in the A2 window, but LA1C, basically anything beyond 16, it goes into LA1C. So this 25.4 is fetal hemoglobin. What cutoff did I tell you for A1C reporting? 10%, right? So this 25.4 is not reportable. So you will not report this A1C. And like I said, it's interfering. That is why 3.3 is the value. This is not at all reportable. 3.3 is not possible. So this A1C plot is not reportable. So what would you give this out as a report? You will give it out as HbA1c, you have to mention in your column not reportable. You'll put a comment saying HbA1c is not reportable because of probable interference of hemoglobin variant and test by fructosamine test. And also you will suggest suggest hemoglobin HPLC for confirming which type of hemoglobin is there in that. Fetal hemoglobin high, probably HPFH or delta. Okay, so the fetal hemoglobin in adult, like I said, is less than 1% usually, but there are certain conditions in which it can be physiologically increased, but usually it doesn't go beyond 10%. Physiological increase can happen in cases of pregnancy, high altitudes. These are the common areas. Sometimes in aplastic anemia, some drug therapies like hydroxyurate therapy, or in thalassemias, when thalassemias, it can increase. It can increase in delta beta thalassemia, or it can be in hereditary persistence of fetal hemoglobin. So all these cases, fetal will increase. So HbF, why is it important? Why are you not giving out this? Because one is interference of this, and the second is HbF does not give out the value of A1c. Our primary interest is A1c, not any other variant. So two important biochemical reactions that we already told. HbF contains the gamma chains. HbF does contain the gamma chains, but it cannot bind very clearly. The glucose cannot bind at the same level with the fetal hemoglobin. That is why there is an interference. So one thing is cation exchange high performance chromatography like this has a significant advantage. When you do these testing of fetal hemoglobin with immunoassays, boronate affinity, or with enzymatic methods, you will not be knowing whether the variant is interfering with the results or no. But when you do a cation exchange HPLC, it offers a significant advantage where it clearly separates the HbF peak from the A1c. So there is an accurate identification also, and that is excluded. So whether it is reliable like in this case or it is unreliable like in this case on the right, you can decide. So report this off, do not report the one on the right. All right, so like I said, this is how you would give it out, saying A1c is not reportable due to presence of high HbF. All right. So let's look at this plot now. So if you look at this plot now, what are you seeing here? You're able to see that first look at the total area. I'm just getting you used to the way of looking at the plot. So I will be repeating myself again and again to look at the plot, look at the peak, look at the baseline. So that is how you have to report. So look at the peak, acceptable. This is acceptable. This is acceptable. 1 to 5 million was our cutoff. Then we look at all the peaks. The peaks are all sharp. They are touching the baseline. So all of them, this is a valid type of analysis. Then you look at what are there in the different areas. So A1A, A1B, you're seeing LA1C. A1C is also there. There's a certain value. P3 is okay. It is not degenerated. It is below 10%. So it's fine. So then you see there is an S window. The S window is showing how much? 33.8 in this peak. Then we move on to the next one. In the next peak, what are we seeing? Acceptable area. Then you're seeing all the plots are also acceptable. What are you seeing here? You're seeing an S window again. S window of 30.9. In the third picture, what are you seeing? Acceptable. Peaks are okay. And then you're seeing an A1C result of 5.4. But you're seeing an unknown here as 27.6. But did you notice that this is 1.65 here, 1.65 here? So basically, this is a sickle heterozygous plot run in A1C mode. So when the sickle heterozygous is there, the D10 instrument is picking the variant as sickle. Some of the instruments just give you a HV or variant window. Otherwise, you either see it as a variant peak as in torso, or in this, you will be able to see it presents it as an S window itself. So what did I tell you was the cutoff in the beginning when I spoke to you about the variant? I told you the cutoff was 40% for reliability of the A1 result. So all these three plots that are here are giving you within 40%. So all of these peaks are okay to report. So you can report the A1C result for any of these. So the 6.3 in this, or 7.4 here, or 5.4 here, all of them are reportable A1C results. But all of them have an S window. If you're trying to understand why this has come as an unknown window, sometimes there can be a problem in the instrument where there can be a small calibration error, because of which the sickle window did not get picked up at this retention time. So when you're seeing that there is an abnormal window with a known retention time that is picked up as unknown by the instrument, you need to recalibrate the instrument again for it to understand all over again that this is the NS window. So all of these peaks are, for technical purposes, all of these peaks are reportable. all of these HbA1c results are reportable, and you would suggest that the person would run an A2 a hemoglobin HPLC to pick up this S window. So you will only restrict yourself to A1C assessment here. You can call up the clinician, tell him there's an S window, and you would want to give you would suggest a hemoglobin HPLC. Okay. Let's look at this peak now. In contrast with the last one, if you remember here, you hardly see anything else. Most of the peak is eaten up by this one peak, which is a variant. Almost, this is actually a sickle homozygous. Almost 90% of it is the sickle. But just the carbamylation and there are two peaks here actually within this one. This is a sickle homozygous. So in the sickle homozygous, you are able to, you cannot report out the HbA1c here. And there usually is no HbA1c at all. If it is a homozygous beyond 60% is occupied by the sickle, you may not see a HbA1c at all. And even if you see a small amount of HbA1c, it is not at all reportable. So do not report this peak. So what would you say? A1c is not reportable due to presence of a variant hemoglobin that was sickle homozygous. And then you would say, you would ask them to do hemoglobin analysis, hemoglobin HPLC for confirmation. So let's look at this peak now. The total area is acceptable. 1 to 5 million was our cutoff. The peaks are all touching baseline. The baseline is straight. So what do you have here? You have one abnormal peak at 1.76 here. So this peak is the hemoglobin C. So this is hemoglobin C. But what amount of hemoglobin C is there here? It is 27. So it's within the 40% cutoff that is mentioned by the manufacturer. So this A1C is reportable. So here you would report a hemoglobin A1C of 5.1 for this particular patient. Let's look at this peak now. So this total area is acceptable. And what do you see here? You see an additional peak after AO. This is the AO peak here. And then you have another peak here. What is the other peak here? That is the hemoglobin E window, which is 28.5. This 28.5 is HPE window. So this HPE, is it within 40? Yes, it is within 40. So this A1C is reportable? Yes, it is reportable. So that again, the same thing. There is an interference with the variant. So you would suggest that this is a reportable A1C, but you would still mention that there is a variant of a small quantity and ask them to do the A2 window for confirmation. Now let's look at this plot now. So in this plot, you're able to see the AO, and with that, you are seeing one more peak, which is in the range of 39.4. So this is DS window. So you cannot separate out the D and the S in a Biorad D10 system for A1C mode. If it's an A2 mode, it will get separated out because it's a longer processing time and it will get separated out. So in case this patient, we had given out the A1C, this is almost 39.4, but the A1C was, we can take a cutoff of 40. So this is still reportable. So you can give it, but then you have to suggest to the clinician that there is a significant other peak in this. So here, in case you ran this in A2 mode, then you would probably see that there is a D. This is I'm just giving you another example. It doesn't belong to the same patient, but this is an A2 window that is done. So in case of A2, you see the hemoglobin D Punjab as 3.86 plus or minus 1 area. So this is a HBD Punjab, and this is a HBS. In case you had suggested to the patient that this has to be done in the A2 window, and if you had run, you would find one of these two peaks in this patient and you would report it out. The A1C, however, is reportable. Let's look at this. Is the A1C reportable in this at all? The A1C is showing the value of about 49.3. It is not at all reportable because this is actually an interference because of a hemoglobin variant. It can be an Imogen or a HOPE, which goes and elutes very close to the A1C. But in case you see a very high A1C like this, do not report it out. Ask for an A2 window ask for them to bill for an A2 window, or you run an A2 window. Make sure that it is separated out. Don't report 49.3. So that is, this is an abnormal variant that has eluted at the A1C itself. So this is not reportable. Okay. Again, you would give the same thing that you would want the patient for glycemic index to be checking out the amount of glycemic control with fructosamine test. So one new thing that I wanted to tell you, that the Diabetes Care Manual of American Diabetes Association, which was published in 2024, has clearly mentioned that A1C cannot be measured in an individual with HBSS, which is sickle cell homozygous, or homozygous E variant, any of the homozygous E variant who almost lack the HbA. And an alternative has to be used like fructosamine test. So that is very clearly mentioned in the care document also. So moving on to the clinical significance of A1C. One, it's for the diagnosis of diabetes mellitus also as a subsidiary to the cutoff that we use as fasting blood sugar 126. It's a subsidiary to that. It is useful to the monitoring of the glycemic control. It is a predictor of diabetes complications, and it is also useful for therapy related adjustments, and ADA and WHO recommends A1C of greater than 6.5 as a diagnostic threshold. So that is something that you have to understand. So whenever you're looking at this long-term monitoring, in the sense where you have to make sure that the traceability is good in your instrument. Your instrument has to give the correct values every time that is run. Otherwise, the treatment will fall in trouble. So what are all the factors that cause low HbA1c? So whenever there is increased RBC destruction, there can be, whether it's a hemolysis because of any intravascular hemolysis or extravascular hemolysis, any hemolysis, there can be a low HbA1c. If there is a hemoglobin variance affecting RBC survival, then also there can be a low A1c. Suppose there is a sickle cell anemia. Usually sickle cell anemia patients, the RBC lives only for 60 to 50 days. Usually it doesn't live up to 120 days. So you're detecting hemoglobin A1c fraction in an RBC that is living only 50 days or 60 days. So A1c value naturally comes down. And another important thing when I'm talking about sickle is also that the sickle adherence to sickle to the glucose, which is HbS1c, is not at the same level as HbA1c. The affinity itself is low. So when there is an interference with that, so that is why you have a cutoff set that if it is beyond 40%, don't report that A1c, it's unreliable. So it's because of multiple factors. One is the hemolysis. Second is the adherence of the A1c to the sickle itself, and the life of the RBC, the lifetime of the RBC that it spends in the human body. All of these bring down the A1c level. So next factor that can cause falsely low A1c is recent blood transfusion, because whenever you have a blood transfusion, it's an admixture of the existing patient's milieu with another foreign milieu. So when that happens, naturally, if you're infusing a person who relatively normal is usually the donor, so the donor HbA1c levels will be okay, and your recipient is having way high. You have a mix-up, so definitely there will be some lowering of HbA1c. Acute hemorrhage, definitely the blood loss is there, RBCs are lost, A1c goes down. Elevated serum triglycerides is also an interference. So during the sample acceptance itself, we obviously don't accept HIL. So hemolysis icterus lipemic, we don't accept. It's the same thing that applies for this analysis as well. The next is drug-induced shortened RBC survival. There are so many drugs that cause hemolysis. For example, the anti-malarials can cause hemolysis. There are so many drugs which you give out to the patients for multiple treatments, which can cause shortened RBC. So as a clinician, when the clinician is actually looking at the A1C result, he has to keep in mind whether if there is a new drug that you're installing, you're giving along with it a hemolytic drug also for treatment of malaria, let's say, or malaria in itself can cause hemolysis. So any of these conditions you have to think before changing the medication for glucose. Is this A1C actually come down because of lifestyle changes on the medication I've given, or is it because of hemolysis that it's come down? So that is something that you have to keep your eyes open for and think on the clinical side. Then chronic hepatic diseases. Any of the chronic hepatic diseases can cause one, impaired production, increased hemolysis, both of them. So that's a vicious cycle. So there also, and also you can have a concurrent iron deficiency, B12 deficiencies also, which can lower the A1Cs in a patient with chronic hepatic disease. So sometimes falsely elevated A1C can occur in iron deficiency, anemia, B12 deficiency. Alcoholism can also cause. Sometimes you can get falsely elevated A1Cs as well. Renal failures also can have a slight increased A1C levels than compared to a normal individual. Raised bilirubin levels also can interfere. Bilirubin will be in the pre-analytical left side peak in the corner within 1 minute. So those areas you will be able to pick up bilirubin there. So you have any interference. One thing you can do is you can centrifuge the sample, separate out the serum, and then repool it with the same quantity of buffer, and then try to run it. That is a complicated reaction which only experienced people can do. But if there is bilirubin and excessive icterus, then you can call the clinician, wait for that to subside, and then decide on what the A1C looks like. So drug analytical interferences, there's a long list of drugs that can interfere with the A1C results. And some unpredictable factors. For example, elevated fetal hemoglobin. The percentage is the prediction. Less than 10%, you're good to go. Greater than 10%, it is unpredictable. So then presence of methemoglobin. Methemoglobin also factor that is a very labile thing which changes according to the time at which you've taken it and according to the amount of methemoglobinemia. So that is also an unpredictable factor. Then structural hemoglobin variants also has unpredictable effect on A1C. So these are some things I wanted to clarify. Then there is an interesting article which I wanted all of you to read. So the higher glycation of HbS compared to HbA by mass spectrometry. This is a very interesting article. If you find time, you can read it. And clinical significance of A1C, I already told you, it plays a crucial role in all these as a predictor of diabetes complications. So it reflects the average blood glucose, as I said, of about 8 to 12 weeks, and short-term fluctuations can happen because of stress, meals. All of those don't affect the A1C results. So that's the reason you pick up A1C for monitoring. It's a gold standard. And some therapy-related adjustments, it's very, very useful. So this is a chart in which you know that a normal is below 5.7, pre-diabetes is 5.7 to 6.4, and for a diabetic greater than 6.5 is taken as a cutoff. But there is also this chart in which you have the A1C results and average blood glucose predictability. So this chart is extremely useful for a clinical interpretation for the clinician, where counseling, therapy, adjustment, and monitoring of the treatment response is very easy once you look at this chart. For example, if there is an A1C of, let's say, 5%, which corresponds to an average blood glucose of, let's say, 97 milligrams, while that of about 6.5%, it corresponds to about 115 to 120. So a cutoff of 126 is already crossed if it's going beyond 6 years, correct? So the average blood glucose predictor chart is very useful for the clinician. So even a 1% increase in HbA1c reflects an approximate increase of about 30 milligrams per deciliter of the average blood glucose. So that is something which that chart will be very useful for. So in my session, what did we discuss? Let me summarize the whole thing for you. It was been a little long. So in this session, we have comprehensively explored the biochemical basis of HbA1c first, and then we looked at the aspects of A1C testing with a strong focus on the practical applications and the clinical correlation. So to begin with, we understood the biochemical basis of A1C formation, which includes how the glucose binds to the hemoglobin through non-enzymatic glycation first, which reflects the long-term glycemic control in a lifespan of 120 days. Then this foundation was essential for us to understand chronic glycemic control. Next, we reviewed the different laboratory methods available for the A1C measurement. In particular, we had an emphasis on the HPLC, which is the topic for today, which remains one of the most widely and analytically robust technique. So then we moved on to the principles of HPLC separation and how the hemoglobin fractions are separated on the basis of their charge differences, and how the chromatograms, we looked at all the chromatograms, then we looked at the individual peaks, we looked at what is the acceptable peak, and then following which we ran through the stepwise methodology of A1C analysis using HPLC, covering chromatographic separation, peak distribution, and then looked at the final results of several examples. Then we systematically interpreted all of the chromatographic peaks that were available, which are possible to interfere. And we looked at the patterns, we looked at the results validity, and then we recognized the analytical interferences that are very common with hemoglobin A1c. And then we looked at the clinical correlation today. So this ends my topic for today. So I would like to also mention to you that I have published a book very recently, which is One Line Wisdom and Practical Pearls of Hematology, which is available in Amazon. I would suggest that any of you can use this. I would send the link to the organizers right here on the chat box. So that ends my talk for today. Thank you.
Thank you very much, Dr. Deepa. It was in-depth analysis of the HbA1c interpretation itself, and I'm very grateful to you. So we have Dr. Satish Ramanathan, who will be taking over the next stage to talk something about the interferences in the HbA1c. It may be some repetition over the first speaker, but I think it is better we understand those interferences in depth so that we'll be able to understand the interpretation of the HPLC graph itself. So I'll just hand over to Dr. Satish. This next topic will be managed both by me and Dr. Satish Ramanathan, and I'm 100% sure that we'll be completing the session before 4:25 today. Thank you very much.
Okay, so good afternoon. So Dr. Deepa, she explained everything so nicely, and she was talking about interferences, right? So excuse us for the interferences from our end because of some IT issues. So this interference do occur in our day-to-day life. So there might be repetition in terms of my topic because Dr. Deepa explained everything and she covered almost everything, I would say, holistically. And I was happy to see a pathologist talking about Amadori effect and two-step glycation of hemoglobin. So thanks, Deepa. So I am just going to my presentation. Just a minute. Okay. So this is a case wherein one fine Monday morning in a laboratory of mine where I was working, there was a call from diabetic OPD for the HbA1c result of 50 years old diabetic Bengali woman. So she was from West Bengal, which is in eastern part of India. And so we checked with the department. The sample had been processed twice, but without a value. So HbA1c was reported as not reportable. So it was the same scenario which Dr. Deepa explained with few cases. So it was not reportable because HbA1c was not seen. But the clinician was furious because when we called him to inform that HbA1c can't be reported, so he being a diabetic doctor, diabetic specialist, so he needs a value, right? Okay. So this is what that occurred on that day. So this is a chromatogram which you are seeing. So there is a huge peak which is black in color here. So leave all these, but just when we go down to these fractions of hemoglobin, we can't find HbA1c here at all. So because this technology HPLC has been designed specifically for A1C, right? But we can't see A1C. So the random blood sugar is 102, fine. So but what to do with hemoglobin? So what we did was that we had a practice which was very holistic and it was based on specific guidelines. And this was based on a guideline called as British Society of Hematology, BSH guidelines, wherein minimum of two methods are required to rule out a hemoglobinopathy. I mean a hemoglobin variant. So one is HPLC, another one is electrophoresis, capillary electrophoresis. So what we found out was that it was hemoglobin E. So hemoglobin E is a variant and it interferes with the HbA1c estimation, especially when the percentage of hemoglobin E is so much. It is 85.7%, so there is no A1c. Okay, so now let us keep it very simple. As a laboratory medicine specialist, I have and I will be having two questions which always will be in my thought process with respect to HbA1c. What are those? First one is, do we really need to give so much importance to HbA1c and its measurement? And second one, does the impact of interferences, including the variance on HbA1c measurement, is so much? So are we assuming that the interferences are so much to be considered, to be discussed, and to be learned? So these are the two questions. So let me run through the first question. Let us try to find an answer to the first question. Okay, so basically that is the intention. So do we need to give importance to HbA1c and its measurement? So answer to this is yes, absolutely. Again, there is a repetition of Dr. Adipa's slide, but see here, just we have 4 points here. Okay, see these 4 points, they indicate that A1c is intertwined with diabetes from the scratch. From the scratch means HbA1c is needed for diagnosis of diabetes, though it is not being widely used for diagnosis. I'll come to it little bit later. Of course, it is a gold standard method for glycemic control. So a patient with diabetes, whether he is in control or not, HbA1c periodic measurement once in 3 months should be considered, and there is no alternative for that. Second, HbA1c doesn't stop there. It also penetrates into the diabetes in terms of complications. So we know that diabetes has so many complications like neuropathy, nephropathy, retinopathy, diabetic ketoacidosis, hyperosmolar coma, so much is there. But what we need to understand here is that HbA1c is a predictor of diabetic complications. So more the HbA1c, more is the risk of complications of diabetes, and the vice versa. If it is less, the complications will be less. Okay, so this last point I created this to understand that HbA1c enjoys monopoly. There is no other alternative till this day to replace A1c, though people talk about the alternatives like fructosamine, glycated hemoglobin, glycated albumin, but they are not in a position now to replace A1c and even substitute A1c. Fine. So coming to the clinical signature of HbA1c, this is a beautiful representation from ADA, American Diabetes Association, and so this gives reference interval for A1c, which can be used in all the laboratories where you are all practicing, all the attendees of this lecture. So this is quite simple, extremely simple. Has just 3 points: reference interval in a non-diabetic, reference interval when the patient is on treatment for diabetes, the target should be less than 7. If at all the therapy needs to be changed, so the clinician needs to consider this cutoff. More than 8%, go for change in therapy, because it means that the retreatment is not responding, or the diabetes is not responding to the treatment. Okay, so that is it. And this slide, I love this slide. Why? Because see, A1c has been seen as a marker for glycemic control, but come to the diagnosis of diabetes, till this day we use OGTT, the oral glucose tolerance test, which is cumbersome for the patients. This has been a recommendation from ADA, American Diabetes Association, saying that A1c with a cutoff of more than 6% in a non-diabetic individual can be considered for the diagnosis of diabetes. So this avoids a cumbersome procedure in terms of fasting, in terms of waiting time, the length of stay in a hospital, and this can be considered to be started in India. Till this day, no one has used this as a cutoff for diagnosis. Okay, so that is there. So that is why, so this is a reason why we have to consider A1c as a very important test. Okay, so having said that, I will just run through very swiftly through this part. See, we all talk about the graphs, we all talk about their interferences, variance, but where does it start? Where do we start, or where should we start? As a laboratory medicine specialist, I need to understand before starting a methodology, before buying an instrument or getting an instrument through reagent rental, I need to understand how to select a method. Though this lecture is limited to A1c, this is applicable to all the measurements, all the analytes which you are testing in your laboratory. So this, I would call this as a method selection check post. Okay, so why check post? Because we need to close the check post, analyze, and then open it. Okay, so in this way, the HbA1c methodology should be NGSP certified. I'll go into NGSP in a slide, where I will explain what that means. And second, of course, impact of hemoglobinopathies and interferences. Yes, Dr. Deepa has run through these interferences in detail, but we will also show some of them, because see, this is a learning session wherein more and more you see the graphs, you start to understand the pattern that goes into the memory. It will become a photographic memory for you. So don't worry, even if it is a repetition, it is a learning session. Okay, so just 2 minutes on NGSP. Okay, so this diagram, okay, this is from NGSP website. So to start with, what is NGSP? So NGSP stands for National Glycosylated Hemoglobin Standardization Program. Okay, so this is in US. So what NGSP has as a network is, it has reference laboratories. So if you can see here, there is a central reference laboratory, then primary reference laboratories, then secondary reference laboratories. What these laboratories do, these laboratories have HPLC, that too cation exchange cartridge, and I don't want to mention the company from where the NGSP buys the cartridge, because it will become a financial conflict of interest. So this methodology of HPLC is there. Fine. Then what does it do for a laboratory? It is not for the laboratory, it is for the manufacturers. It is for the instrument manufacturers. Okay. So, for example, a manufacturer of an instrument wants to start a methodology, get an instrument. What he does is that he actually goes to the NGSP. He submits the samples for HbA1c. He submits the calibrator. He submits controls. So now there is a program wherein these samples are analyzed both in the reference laboratories of NGSP and in the manufacturer's premises. And NGSP defines whether this method is acceptable or not. Okay. So in this way, if the NGSP says that yes, you can go ahead, then that method becomes NGSP certified. Okay, that is one. And second thing, I wish to include this also. It might be little bit too much, but I'll have to mention this because it is critically important. In this slide, can you see this on the left side of the slide? IFCC laboratory network. Okay, so we all would have heard about IFCC, International Federation of Clinical Chemistry, right? But with respect to hemoglobin A1c, HbA1c, what IFCC has done is that it has developed the highest order of method or a reference method, which is capillary electrophoresis coupled with mass spectrometry. So IFCC having the upper hand, what NGSP does is that it has a tie-up with IFCC to ensure that the quality of NGSP certification is valid. Okay, so see why we need to remember this and what we need to do from this is starting here. Okay, so this slide, it shows a list of NGSP certified methods in the website of NGSP, and it is updated every month. For example, you are going to select a method from a manufacturer, you can just key in this website and see whether the manufacturer's name is there, whether his instrument name is there, whether the particulars of reagent calibrator as in everything is there. Then you can just go ahead with the method. You need not ask the manufacturer. Fine. So this is critically essential for a laboratory to understand and follow. So you just need to do only this. Go to the website, key in NGSP certified methods, and it will be displayed. Fine. Okay. So first question, I think that from my end, I have got an answer to why we need to give so much of importance to A1C measurement. So now going into the second question, the impact of interferences on A1C measurement, I would request my mentor, Dr. Srinivas, to run through the interferences from his end, and then I'll catch up with few cases to end with. Sir, it's up to you.
Thank you very much. So we will just see a brief capsule of summary of what are the interferences, what we get on the HbA1c measurement itself. So I have just taken a small classification here to make it very simple to all. So usually the HbA1c, which is measured by the cation exchange method, has got two main interferences. One is the analytical interferences, other is the biological interferences. When we are talking about the analytical interferences, we can classify them into two. One is the hemoglobin variance, another one is the chemical modification and the laboratory errors. Coming to the biological interferences, short RBC life and the long RBC life. There is nothing called as a long RBC life, but to make us understand that whenever there is retention of the RBCs in the circulation for a long time, then we will be having the biological interferences. Now, whenever you come onto a graph, Dr. Deepa has already explained how to interpret it, but just to make you understand, I have taken the other way. This is the retention time on this, that is 0, 1, and 2. So this is the retention time on the HbA1c mode itself. So you have got graphs and peaks over here. So these are 0.2, 0.3, 0.47, 0.5. So what do they mean by that? That is getting classified into A1A, A1B, and the hemoglobin F. So hemoglobin F is here, which is 0.47. And when it comes to the HbA1c, it gets on to the retention time of 0.89. So approximately around 90 seconds, you can say. Next is you have a P3 over here, which comes here at 1.37, which is clearly demarcated here. This is the P3. And the A0 is around 1.46. So here the black peak, what you see, the HbA1c is around 6.4. This is the normal to understand how you're going to do it. So you make sure that this, we have just changed the direction of the graph representation for easy understanding. Now coming to the analytical interferences. So we'll finish off the analytical interference, then go to the biological interferences. So as Deepa had shown, there is a lot of hemoglobinopathies which comes into picture, like hemoglobin variants like hemoglobin C, D, E, and S. And a high fetal hemoglobin of more than 10 to 15% are the commonest reasons. Analytical interferences, when you have a chemical interactions like carboxylated hemoglobin, as in cases of uremia, renal failure, you have got false high in the ion exchange methods. Acetylated hemoglobin, as in those acetaminophen poisonings, you have a high false high values of the HbA1c. The icterus and the bilirubin do have some impact on interfering on the specific assay readings itself. Coming to the biological interferences, which had been already told across, but to make it very simple to us, whenever the red blood cells life is very short, like in hemolysis, hemolytic anemias, which is genetic or acquired or even drug induced, or any of the chronic blood losses like hemorrhage or frequent blood donations, you will be having altered values of the HbA1c. Next, stagnated RBCs, like we have circulating longer than the usual allowances, will be like deficiencies, anemias, or the vitamin B12 deficiencies, folate deficiencies, and sometimes on asplenia itself. So we have understood that there are interferences between both biological and analytical interferences. I've just given you a capsule of it. So Dr. Satish will take you around with each of these cases with the interpretation of the graphs for you to make it easier to understand how you have to read these values itself. Over to you, Dr. Satish.
Yeah, thank you so much, sir. So yes, we'll take another 5 minutes to go through the interferences. So this will be like a troubleshooting spree wherein we'll just go through few cases with interferences and mechanism of interference and how to take it in your daily practice. So already sir has explained, but this is little bit different in a way wherein what are all the hemoglobins, what is the kind of interference, and what are the interferents. Okay, so A1A and A1B are the first fractions because they are very small and their charges are less, so they come out first. They become high in terms of bilirubin and hemoglobin H. I will be showing those cases. HbA1c, yes, high, it occurs in HbF. I don't want to explain this again and again because this has been covered in depth by Dr. Deepa. So this slide, I would like to just make you understand that throughout the chromatogram, throughout the peaks, starting from A1A, ending with P3, and it also goes to A0, there are interferences in terms of both chemicals and hemoglobin variants. Okay, so yeah, this is what I wanted you all to focus. What happens to A1A and A1B? These are all very small fractions which appear first in the chromatogram, okay, before the A1C. So bilirubin, when it is high, it can impact the first fraction, wherein A1A is 4.1, 1.1%. Okay, so bilirubin can interfere. So that is one. Second, I have not put a slide on triglyceride. Why is triglyceride being considered in A1C measurement? For which I have a little bit different answer, in a way that triglycerides, high triglycerides indicate hypertriglyceridemia, right? Dyslipidemia. So now there is a concept of something called as metabolic syndrome, just a little bit out of this topic, but I just wanted to cover this metabolic syndrome or syndrome X. So this is a syndrome wherein the patient has diabetes, the patient has hypertriglyceridemia, and the patient has hypertension. Fine. So now we have to consider all these three together, and among these three, triglyceride and HbA1c, they are now put together in a bracket, correct? So we need to consider triglycerides also. So what the kit insert of the manufacturers of HPLC says that even even more than 500 of triglyceride doesn't impact A1C measurement in HPLC. So we need to verify whether that happens in daily practice. So that is what I wanted to explain to you. Okay, so now just 1-2 minutes of explanation of what HbH means by HbH or HB bars. They are alpha thalassemias and they occur as twin peaks. So again, this was shown by Dr. Deepa. This was from our laboratory, our practice. So twin peaks are there, and the value of these peaks 16.6, 23%. These are usually less than 2%. Okay, so this is alpha thalassemia. Next, interferences with A1C. Okay, so we have finished A1A, A1B, right? Now coming to A1C. Yes, again, I have to mention Dr. Deepa's name inevitably because she has covered everything. So here it is hemoglobin F, and it is coming out in carbonylated fraction because these fractions are very close to each other. So they overlap 22.9%. So in this case, we can't report A1C because as she rightly said, more than 10% in D10, we can't report HbA1c if at all the interference is there. Fine. So going to, yes, see this false high A1C, we are talking about the errors which happen physiologically, I would say pathologically, but instrument-based errors do occur and we need to understand those also. So here I would like to give credit to our senior technician with whom we had worked, Mr. Madhivanan, who was working with us as a technician in charge for hematology. So he was the one person who taught us so much. See, that is one lesson we need to learn here. When we are in a laboratory, when we want to evolve as a laboratory medicine specialist, we need to learn from everyone. We should be a learner and we should be a teacher. So that is what I wanted to emphasize here. He gave this slide and we learned from this. See, this is elution buffer error. And what happens here is that, see this, the values, one value is there, A1C 22%. Can you see 22% here? This is A1C. So it means that there is some error, and he has found out that it is elution based error. And when it was rerun, we got an A1C of 5.7 or 6.7%. Okay. So this is one lesson I want all of us to learn during this session. So the next one, yes. So this is very low A1C, right? 3.6%. And as Dr. Srinivas and Dr. Deepa said, this might be due to hemolytic anemia. See, the hemoglobin is 4.2%. So this is in vivo hemolysis. Okay, so the false low A1C can occur both due to in vivo and in vitro hemolysis. In vitro hemolysis, one good thing is that we can redraw a sample and see, and then you might get a valid A1C result. Okay, so I have three more slides. Okay, so interferences. Yes, we talked about false high interference or a false low interference due to what was that? Due to the elution buffer error. Okay, now this is again analytical error due to migration. See, again, this was also covered by Dr. Deepa, but I just wanted to emphasize that each and every point which is put up in this chromatogram representation has a meaning. And we have to understand that. Here, what we need to understand is that, see this, on the left-hand side, I am pointing my mouse at A1C, which is 6.5%. So it absolutely appears to be fine, right? But FBS, fasting blood sugar of the patient, is 450 milligrams. If at all the patient has not done FBS, and if at all we had not understood the chromatogram properly, we would have leisurely released this value of 6.5. But what happened? We reran the sample and the HbA1c value was 10.5. From 6.5, it is going to 10.5, and 10.5 is matching with FBS. So the culprit here is a total area. See, total area of migration is extremely important. It is between 1 million to 5 million. See, here it is 90,000. So it means that there is some problem in the run of A1C. We should not consider this. We have to rerun the sample and we have to come out with a total area of more than 1 million. So same patient, 10.5%. So the last slide, that is on P3. So yes, Dr. Deepa also talked about P3. See, P3 is the peak which occurs or which appears after A1C. And yes, as she said, it can occur because of degeneration of sample, especially when it is a standard laboratory, you are seeing A1C from several places which are far away. So degeneration can happen. But one more hemoglobin variant also can occur in this, which is very interesting. More than 10% usually P3, it would be possibly suggesting the presence of a variant called as hemoglobin J. So that is it. Okay, so I am ending my lecture here. So what we are taking back home, or one is, yes, get an NGSP certified method. Second, gear up for improved precision accuracy. Though this precision accuracy, it is purely analytical. You can find it in the NGSP website, how much precision your method should have, accuracy your method should have. So educate your lab. See, this part I love. These two. Educate your lab personnel, implement GCLP. What GCLP means? Good clinical laboratory practice. So let us learn this from our lecture and let us educate all your laboratory personnel after you finish this webinar listening. Okay, so thanks so much for the opportunity, sir.
Thank you so much, Dr. Satish. So we saw that the HPLC graphs are a bit tricky, and even for a beginner, it might be giving us some troublesome shoots, and we might be getting into trouble every day. So we are talking in the era of the artificial intelligence, and we have to know how artificial intelligence can help us out in HPLCs, interpreting of the histograms, and whether it will be able to help us in auto verification mode. It can help us to even tell whether this sample is having hemoglobin interference or interferences from the urea or hemolysis. So for this to understand about the most exciting part of the role of the AI in HbA1c will be taken by Sridhar, and he will take about 10 minutes of your time. I request you all to be sitting on your seats to understand how these graphs can be beautifully interpreted by the adoption of the AI in our practice itself. Over to you, Sridhar.
Thanks, Dr. CNS.
Yeah. Can go ahead.
Thanks, Doctor.
Your slides.
Can you able to see my slides?
No, we can't see your slides.
You can see you, but
you have to share your slides.
I shared it.
I can see, sir.
So you can see that. Am I correct?
Yes, I can see.
Okay. Thanks, Dr. Deepa. Good afternoon, everyone. Thanks for your participation and happy to launch AI product on HbA1c in this webinar. So as you know, in many laboratories today, validating HbA1c reports remains a manual and time-consuming process. Technicians must carefully review both the quantitative results and the chromatogram, checking each parameter and peaks individually to identify any abnormalities. This slows down the overall workflow, increases the risk of human errors, and take valuable time away from more important clinical tasks. So generally what happens, the instruments gives only numeric value, even though if you interface any equipment, it gives only the numeric value. So with the numeric value alone, you can't interpret the HbA1c. You have to go through the chromatogram also. So let me understand the 5 common lab challenges in the reporting HbA1c. Number 1, when numbers in the chromatogram tells different stories. That is, the quantitative value and the chromatogram don't match. The number looks normal and the chromatogram shows abnormalities. And the opposite also.
It's stuck in the first slide. It's stuck in the first slide. We haven't moved the slides.
Okay. Sorry. 1 minute. So now it able to be?
Yes.
Yeah, we are able to see.
So again, I'll take it up. Sorry. Let me understand the 5 common lab challenges in reporting HbA1c. One is when the number in the chromatogram tells you different stories. That is, the quantitative value and the chromatogram doesn't match. The number looks normal and the chromatogram looks abnormal, or opposite, or vice versa. The numbers will be abnormal, the chromatogram will be clean. So validating this becomes complex. This isn't something simple rule-based system can handle. It requires their experience and clinical insights. Second, in high value, if you see in high volume laboratories, the time will be a very pressure, constant pressure. It will be in the constant pressure. Many labs has to process high HbA1c sample, and they have to release the report. So what happens? Mainly they take the HbA1c numeric value for reporting, and they ignore the chromatogram because there's a time constraint for them. So to manage this, it will be a challenge for them to release all the reports. So it creates a risk. Subtle chromatogram abnormalities may be missed, especially when the number appears normal. This is not lack of skill, it is a limitation of time and volume. Another important challenge in HbA1c validation is variability in human interpretation. Not all laboratory staff have the same level of experience, confidence, or exposure to rare chromatogram patterns. While one technician may confidently recognize a subtle abnormal peak, other may interpret the same chromatogram differently. As a result, the same chromatogram can sometimes receive different interpretation by different technicians. This leads to inconsistency in the reporting and greater dependence on the small number of highly experienced professionals. So, the same problem is same in the high volume labs. The same variability becomes more difficult to manage. And one more thing is overlapping of peaks. This is an important challenge where many of the laboratory faces. This is called co-elution. This happens when the variant hemoglobin peaks overlap with the HbA1c fraction, or when fractions like HbF or carbohylated hemoglobin shift closer to the major peaks. When this overlaps is subtle, the HbA1c value may appear numerically acceptable, but the underlying chromatogram tells a different story. If these overlaps are not identified early, they can lead to misclassification or inaccurate reporting. The other major challenge is HbA1c analysis is identifying rare HbA1c hemoglobin variants. Many laboratories encounter unexpected peaks or minor peaks that appears irregular without a clear explanation in analysis standard output. In such cases, traditional analysis software may only report a number and may not be able to classify or interpret these unusual patterns. This puts the responsibility entirely on the reviewer to recognize that something is unusual and decide whether further testing or investigation is needed. When workload is high or experience with rare variant is limited, these subtle patterns can be missed. So Sukra has understood the challenges with the help of pathologists and technicians, and we have introduced BioDoc Extract AI software. This BioDoc Extract is an AI-powered platform designed to revolutionize HbA1c reporting by automating PDF report reading and chromatogram interpretations. Generally, what happens when you interface a particular HbA1c analyzer, you get only the numeric value. You don't get the chromatogram. So few analyzers only provide you the chromatogram. So generally what happens, so the PDF contains both the chromatogram as well as the numeric values. So we extract chromatogram images and tabular data from the analyzer generated PDF, identifies abnormalities in peaks, area percentage, and axis shifts, and flags suspicious pattern for manual review. Normal reports are auto-authorized, reducing validation time by up to 90%. The system also provides clinical correlations by analyzing chromatogram pattern alongside quantitative values, offering insight into potential hemoglobin variants and recommending confirmative tests wherever necessary. This makes BioDAC Extract not just an automation tool, but also ensures compatibility with diverse PDF formats. It helps in scalability for high volume labs and integration into existing LIS. By combining AI-driven analytics with operational automation, it helps in enhancing accuracy, efficiency, and clinical confidence in HbA1c reporting. This is how the software looks like. It has three components. One is the left side is where the sample identification number is shown, and the center component is where all the parameters with the numeric values are displayed, and the right side is the chromatogram. So when you click a particular SID or sample identification number, for those numeric values will be populated in the center where the abnormals are marked as red. On the right side, the chromatogram is there. Our AI engine, what it does, it reads the chromatogram, and if it finds any of the challenges, it shows us the red as a border. It gives a missing peak also. At the same time, it gives the confidence scores. It also gives you the clinical correlations. The key features. This software offers a comprehensive suite of features tailored for laboratory efficiency and clinical precision. First, its PDF extraction engine captures chromatogram images and retrieves all relevant tabular data, including peak values, retention time, and HbA1c parameter, regardless of the analyzer format. Second, the AI chromatogram analysis module detects abnormalities such as missing peak, unexpected area variations, and axis shifts, which often indicates hemoglobin variant or technical issues. Third, the abnormalities flagging system uses color-coded alerts to classify report as normal, abnormal, or require attention, enabling rapid triage. Fourth, the authorization workflow ensures that normal reports are validated instantly, while abnormal cases are held for expert review, significantly reducing manual workload. Finally, the clinical correlation engine integrates chromatogram interpretation with quantitative data to provide actionable insight, including variant detection and recommendation for confirmative testing. Together, these capabilities transform HbA1c reporting into a streamlined, intelligent process. This software is designed to optimize laboratory operation while maintaining clinical rigor. Upon receiving a PDF report, the system automatically extracts chromatogram images and tabular data, eliminating manual data entry. The engine that analyzes chromatogram patterns for abnormalities such as peak distortion, area discrepancies, and axis shift. Reports classified as normal or auto-authorized, reducing routine validation time dramatically. Abnormal reports are flagged and held for manual review, ensuring the critical cases receive expert attention. This dual approaches balance automation with oversight, minimizing errors while accelerating throughput. By integrating the clinical correlation, the system provides interpretive insight that support diagnostic decisions such as identifying hemoglobin variants or recommending additional tests. The result is streamlined process that reduces turnaround time, lower operational cost, and enhance diagnostic accuracy, making BioDAC Extract an indivisible tool for modern laboratories. The benefits are it gives a huge operational efficiency, enhance clinical accuracy, it gives faster turnaround time, and support business and scalability benefits. Thank you for joining us today and exploring what BioDAC Extract can do for your laboratory. Our goal is simple: to help you deliver faster, more accurate, and more reliable HbA1c result with less effort. We welcome you to reach out for a personalized demo or start your trial and experience the difference yourself. We look forward to supporting your lab's journey towards smarter AI-powered reporting. Thank you.
Thank you, Sridhar. That was a great innovation from Sukra, where the graphs are going to be interpreted by the artificial intelligence and get across to that of the histograms and also alert the authorized signatory before they sign whether they have to understand whether there are any interferences. And of course, people will join across with us to understand more about this if they need a personal demonstration of the equipment. So to get back to our question and answer, I think Dr. Deepa is already on the mode of answering some of the questions on the chat boxes. And I have seen there were some of the questions which they've been answered by Dr. Deepa itself. And I also had one or two questions which I answered. So since we are getting on to the time lag of about 4:35 here, so we will be sending you the quiz on your registered emails, and you will be getting this quiz, which are about 5 questions, and you can answer to us, and you can send it back to us, and we will review with the answers, and we will get you this. So thank you so much for the Deepa to take her time off and to share her rich experiences with us, in-depth analysis of each of the graphs. That was a beauty to understand how the HPLC can screen for hemoglobinopathies and also alert about the uremia and the lipemia and other interferences, which can give actually a clue to the diagnosis for the disease in question itself. And I would also like to thank Dr. Satish Ramanathan for taking his time out of his routine and to be with us to discuss about the interferences in the HbA1c. And thanks to Sridhar Paripurnam, founder and director of the Sukra Software Solutions, for taking his time for pitching us to introduce about the AI and its utility in interpretation of the HPLC graphs for doing an authorized reporting safely, and the patient safety can be enhanced. So let me just review any of these things which you have gotten. Any questions? I think it's only the concluding vote of thanks as well as that of thank you for all of us. And thanks everyone for joining us here today. And we really apologize the initial glitches from our side for the software. And thank you, Deepa. Thank you, Sridhar. And thank you, Satish Ramanathan. And thanks for all the delegates who were here today to make this event a successful event. Thank you.
Thank you, everyone, for joining. Thank you for the opportunity, sir.
Thank you. Bye.